So my name is Francois de Brandt, and I have been working on payment reform, different types of payment models, benefit incentives for plan members, quality improvement programs, and other initiatives to try to improve the way in which the healthcare system functions for individuals for the better part of 25 years, seems like a long time, and have learned a few things along the way that hopefully you will find useful. A few words before we get into the presentation and the discussion today. One, there's a fair amount of data in what I will present, and so I want to make sure that you understand the data that are being presented, and do not hesitate to raise your hand if something is not clear, because if it's not clear for you, there's a good chance that it's not clear for others. And so don't hesitate, ask the question, we'll stop, go over the information so that I can make sure that you really fully understand what's being presented. So let's not wait until the end, but if you have a question during the presentation portion of today, please raise your hand and ask it. Most of the data that I will be presenting is focused on under 65 commercially insured populations. However, I can tell you that they apply equally to Medicaid and Medicare, but in a slightly different way. And when it does, I will explain how the economics change when you're dealing with one specific category of individuals versus another. So let's get into this. And really, I've tried to segment the presentation portion of today's discussion into really three parts. So the first one is to lay a foundation that will help you really understand when we talk about medical care, healthcare in the United States, but it's really about medical care because this isn't, just generalized healthcare, but medical care. What exactly are the economics? How does the money really get distributed within the system? To whom and to what extent and magnitude? How has that evolved over time? What does it mean for the different categories of providers that deliver care to beneficiaries in different insurance schemes? And then the second one is really how to think about that medical care and the distribution and the economics of medical care as it applies to really structuring payment or reimbursement in a manner that can help provide organizations and physician organizations in particular in really sustaining change so that they can deliver higher value care to any beneficiary in any insurance scheme. And when I say insurance scheme, I mean insurance plan, Medicaid, Medicare Advantage, or under 65 commercially insured. And then finally, what are some potential sources of capital for practices who want to get into this evolving and I think increasingly dynamic world of delivering true value for plan members and their plan sponsors, because those are the ones who ultimately benefit. Both actually benefit from improvements in overall value. So let's start with one example, and I know many of you on this call are more primary care focused than not, but understanding how money is split, in particular in specialty care, is important because it has implications about how you structure payment and how you structure sustainable change in a practice. And before getting into this particular slide, just remember or keep in mind, maybe jot down on a pad, that when you look at the total split in medical care between primary and specialty care in the United States, and it depends a little bit as to whether it's under 65 commercially insured, Medicare Advantage or Medicaid, but more or less the portion of total costs of care, what's paid by any health plan for care in the United States, the portion that's allocated to primary care is somewhere between 4.5%, and maybe 8.5%. In some instances, very rare instances, it can get to 10%. It is almost always less than 10%. So 90% of all the costs paid by Medicare Advantage plans, Medicare fee-for-service, under 65 commercially insured plans, which are mostly self-funded employers, pay 90 cents of every dollar goes to specialty care, 10 cents of every dollar at most goes into primary care. So that's why it's important to understand how the dollars are distributed, in particular in specialty care, because how you structure payment and how you include specialty care in those payments is going to have a very big impact on total costs of care. So for almost all specialties, the minority of the dollars actually go to physicians. The majority of the dollars end up by going into a combination of inpatient, outpatient facility, and pharmacy, DME, and other costs. And here we're not looking necessarily at the split of the dollars by category of service, meaning is it a professional fee, is it a facility fee, is it a pharmacy fee, or is it a durable medical equipment or something else, more than by the category of where that medical spend resides. So cardiology, like most other specialty care in the United States, involves a combination of different interventions towards a patient. Some of it is based condition management. So think of a patient who has coronary artery disease. The majority of the care, one would hope, would go into the management of their underlying coronary artery disease, including pharmacy. However, there's about as much going into base condition management as there is going into acute events. And then the balance is split between minor and major procedures. So in cardiology, think of the acute events for someone who has a cardiac condition as potentially being a heart attack, if it's heart failure, an acute exacerbation of heart failure, potentially a combination of heart attack and stroke. All of those are, think of them as acute events. The major and minor procedures, anything from a cardiac cath to a stent to something major like a coronary artery bypass. And rinse and repeat for pretty much any other specialty, whether it's gastroenterology or neurology, orthopedics, et cetera. So you can see that while ideally you would want the vast majority of money going into base condition management, very little going into acute events, 2/3 are actually split roughly evenly between base condition management and acute events. And the reason for the split being the one I showed is that there are a ton of things that are going on in healthcare that are within the realm of controllable variation. So this slide is not immutable, in other words. There's a ton that can change to both rebalance where the money is being spent, and within each slice, how much is being spent. So let me break down these three different charts, starting with the top left, where a simple procedure like a cardiac stent that occurs at a very high frequency in the United States has incredible variation in the total costs of, or the total price paid, if you want to think about it that way, for that particular procedure. And in this particular instance, in this particular metropolitan area, the prices can vary from close to simple to double. And so the box plot shows the distribution between the 25th and the 75th percentile. So that's 34,000 to 55,000, and then it can go way above $55,000 depending on where that patient gets the care. And this, by the way, holds true pretty much across the different lines of business, whether, again, it's Medicare Advantage, commercially under 65 insured, or Medicaid, although the magnitude of the price differences is going to be far, far greater in under 65 commercially insured than in these other two, because in the other two, the payer ends up by fixing the price. But there is a difference in price whether you're going to the outpatient facility of a hospital, even in Medicare, versus going into an ambulatory surgery center. So price matters, we all know that, and price creates significant variation, which can impact the relative portion of the slice that gets allocated to something like a minor procedure. On the right-hand side is the number of procedures that end up by being done on a given patient by any given provider. So each one of the little dots represents a provider organization that performs stents, procedures, and then the total costs of the management of the condition are costs with procedures on the y-axis, without procedures on the x-axis. And of course, unsurprisingly, when you do more procedures, the total costs end up by being significantly higher. And that goes to the heart of what we know to be appropriateness. And appropriateness is what is, lots of people need procedures done because that's the only way that they can get better. If you have, significant blockage in an artery, you should get a stent. Otherwise, you're going to end up with a heart attack, which we'll tackle in a second. So doing procedures is absolutely necessary in the care and management of patients. The question is, how many should be done? And of course, we've just talked about where should they be done. Both of those are going to impact, again, the size of the slice that goes to minor procedural care. And then acute events, as I showed in the prior pie chart, about 32% of the costs are going into acute events. And in fact, when we look at the distribution of total costs of managing a condition, so in this bottom left graph, what you see arrayed are individuals. So each one of the little lines on the x-axis represents a single individual who has coronary artery disease, and it's arrayed from the lowest to the highest cost for the management of the total cost associated to the management of CAD for that individual over the course of a year. And even though the color difference isn't very acute, you can kind of see that pretty much the base of what should be given to the patients doesn't really vary a whole heck of a lot from the low end to the high end. What does vary are the number, the intensity, the severity of the acute events that that individual ends up by having. And of course, the more acute events, the more expensive those acute events are, the higher the total dollars spent on the individual. Some of that is controllable, some of that is not controllable, and we all know it. There's a very high codependency of the individual. What are they doing to manage their condition? But there is a substantial portion of that that is controllable. And that really truly is, this chart represents, the totality of this slide really represents the essence of what policymakers and others are talking about when they mention value-based care. Value-based care for the individual, for those who pay for the care, the combination of the individual and the plan sponsor, is really giving patients the right level of care so that they don't have a whole bunch of acute events, the right number of procedures, but not too many, at the right place, right, for the right price. That really, truly, essentially is what we mean by value-based care. So if you're the primary care physician and you have no influence over or no contractual arrangements with or that are consistent with that of specialty care providers, you will have a very, very tough time impacting total cost of care. Why? Because again, you're controlling 10% versus 90%. And two, because the individual specialty care provider who is paid purely on a fee-for-service basis for the care that they give, which essentially is evaluation and management, doesn't spend their time thinking about where should I do the procedure? How many procedures should I be doing? Is my patient optimally managed and therefore not going to end up in the ED? It's not that they want them to end up in the ED, but it just isn't part of their compensation. And I learned a long time ago that however shocked one might get when hearing this, if you ask any physician, whether primary or specialty care provider, what are you doing to manage your patient? They will say, I see them when they need me. And that's what I'm paid for. And so unless you change compensation, it's very, very difficult to deliver true value-based care. And that compensation can't just be around what happens to primary care, but also what happens to specialty care. So as I said, this notion of the distribution of dollars, how they're distributed between pharmacy, professional services, outpatient facility, inpatient facility, is very consistent, in fact, across all specialties, maybe with the exception of the MSK, where there is a pretty significant portion of professional services. And that's in large part because in addition to the services provided by the physicians who manage things like low back pain, there's actually a fair amount of dollars in surgical care in musculoskeletal conditions. And so you've got surgical fees included in that darker brown box. But the dark brown box, if you look at it in each one of these columns, and these columns represents, all the dollars spent. This is standardized per member per year for a specific service line. There really is the minority of the dollars, both proportionally and in aggregate, going to professional services. And that's the point. However, where the rest of the money is going depends very much on that specific diagnosis category, where you can see in endocrine, the majority of the dollars are going into pharmacy. And that makes sense because in endocrine, metabolic disease, there's a tremendous component of pharmacy in the management of those patients. That's also true in mental and behavioral disorder, but it isn't true, for example, in diseases of the digestive system. Even though there is a fair amount of pharmacy involved, there's also a lot of facility, both inpatient and outpatient. So as a proportion of all the dollars spent, always remember that the volume of dollars going to professional services is, generally speaking, the minority. And this isn't just true for commercially under 65 insured, but this is really true across all states and across all medical spend. So these data were taken from a study that was done for the National Association of State Health Policymakers, and it shows the distribution across all states of the volume of dollars, so of the total dollars spent in a given state. So that's across Medicaid, Medicare, commercially under 65, the proportion of dollars going into the different categories: dental, home health, hospital, professional, physician and clinician services. And I've highlighted really two of these, which is the hospital portion and the physician and clinical services. And the average for the hospital is about 40%. The average for physician and clinician services is less than 24%. And for hospital, it varies between 35 and 50. For professional services, between 20 and 28. But those proportions are very, very stable across states. And what it does, it means two things. So it means, one, professional services, as I mentioned, only represent less than 25% of the total. B, if you can reduce unnecessary spending across different other categories by a small percentage, 10% across the total, that can result in a very significant increase in revenue for physician and clinician services, right? Because your physician and clinicians get a small percentage, everything else is going everywhere else. So if you have 80% of the dollars going to everyone else, or somewhere around 75 to 80% of the dollars going to everyone else, if you can decrease that 75 to 80 by 10%, so think of it as 7.5% to 8%, then that represents a substantial increase over the 23, 24% that the physicians are getting. right? So these are just it's simple math. We're going to translate it into alternative payment models soon, but this really is the reason why value-based care and value-based care arrangements end up by being very accretive to physician practices when they're done right, because most of the money is going somewhere else. So Gina, is there a question by an audience that I need to answer?
She had to step out for a second, but there's no question so far, unless someone does want to ask a question right now.
All right, and this picture of this differential in totals going to physician services versus hospitals have actually gotten worse over time, and we expect it to continue to get worse in the next several years, in large part because the pricing pressure of hospitals, whether it's in Medicare or in under 65 commercially insured, relative to physician services is just disproportionate, right? The hospitals usually get an increase, and in fact, the prospective payment system in Medicare almost systematically gives an increase in prices to hospitals, and physician services are designed to either go down or stay relatively flat. And that has implications when Medicare sets those rates in Medicaid, because Medicaid very often matches, or even if it's not 100% Medicare, they very much follow what Medicare does. In the commercially insured populations, there's a multiplying effect that I'll show you in a few minutes, where increases in prices of hospitals are actually multiplied by 2 or 3. So that rate of increase ends up by being even larger when you look at different segments. But here we're looking at the evolution between 2013 and 2019. And the increase across states for the prices of hospital versus the increase over the same period of time for physician services. And you can see that there's a significant difference in the percentage over that period of time of the increase in physician services, which are at roughly 1 or 2%, versus hospital services that were higher. And that, so the piece, so think of this in this way: the slice of the pie going to physicians is small and proportionally going to get smaller because the rest of the pie is growing. But as the rest of the pie grows, the slice of the facility pie is actually growing at a higher rate than the slice of the physician pie. So the upshot to a lot of this is that staying in fee-for-service is a losing proposition for physicians. It's just, it's a losing proposition for physicians. It's very difficult as a result to attract capital. If you're looking at this purely from a banker to a business, and looking at the evolution of the revenue of that business and their margins, physician practices operating on a fee-for-service basis are not very attractive businesses unless you want to do something different with those practices. And that means capturing a bigger slice of the pie while delivering significant value to those who pay care. And that truly is what's being done in value-based payment and the financing of value-based payments. So I mentioned earlier that the direction of the increases for facilities is much higher than, and increasing at a much more rapid rate than it is of physician services. And it's even truer in under 65 commercially insured populations, because on average, the rates and the prices of facility services are at 200% of Medicare. So the black line here represents the dollars at 100% of Medicare. The red line is 200% of Medicare, and each one of those dots represents a different facility in the state of Connecticut, and for different types of inpatient stays, cardiovascular stay, infectious disease, GI. And so somewhere between 100 and 200% of Medicare is where commercial prices are, and oftentimes greater than 200%. And in Connecticut, it's somewhere around 200 where it actually averages, in large part because there are a few outliers. In some other states, it's much higher than that. And so that multiplying effect of the price of commercial towards Medicare and the inflationary effect, again, is where it's where the money's going disproportionately, and creating therefore tension in plain old fee-for-service for physician practices. But the good news behind all of that is that you can change the economics in such a way as they end up by becoming quite attractive for physicians. And this is really what a lot of primary and specialty care practices that are deeply involved in value-based care and value-based payments have been doing for the past 4 or 5 years. And so let me start with this example, which, while it's a surgical example, it applies the same way if you do it for conditions, the management conditions, although as I showed earlier, the distribution of the dollars would be different. Obviously, in a procedure, the facility and the price of the facility is going to have a big impact. But in almost all surgical episodes, and this holds true for deliveries, by the way, for those of you who are either involved with or managing patients who are delivering babies, the slice of the pie that goes to the OB or the slice of the pie that goes to the surgeon is less than 10%. Everything else is spent in facilities, pharmacy, other professional services. But as I showed earlier in a couple of different slides, and in particular in the one on the hospital prices in Connecticut, there's tremendous variation in those facility fees. And so this is how you start thinking about payment reimbursement in a manner that's different from fee-for-service, by lumping things together so that what you're pricing out and the value that you're bringing to the ones who are paying for care is the total bundle, the total event, as opposed to each individual fragment. So the individual fragment will always disfavor the clinician because the individual clinician doesn't have a whole heck of a lot of bargaining power, and most of the money is being sucked into the facility. But a small shift, right, a relatively small shift, and you saw the variation in the stents that went from a little earlier that I showed that went from $33,000 to $54,000, and that's a $20,000 spread. Here, it's a little over $1,000, so maybe a little over 10% of the total. And when you look at it from both the lens of the clinician and the lens of the payer, you can offer the payer a better deal. In this case, a 5% discount going from $20,000 to $19,000. So that, by the way, is a saving for the employee or the plan member who has to pay a portion of that total, and the plan sponsor. But it also can result in a significant increase, in this case, 37% for the clinician. Again, this is a procedural example, but you can do this for any number of different things: the treatment of diabetes, the treatment of coronary artery disease, the treatment of mental health, substance use disorder. The dollars are going to be a little different row to row, but the overall picture doesn't change much. The portion going to the clinician is the smallest portion, well, is a small slice of the pie. And that piece can be increased by 20 or 30% by doing things more appropriately. The right type of care in the right setting at the right price. And all of that value can go back to the person who is effectively managing the case, which ends up by being the clinician. So let me start shifting to, using this as a transition to shift to how you ought to think about payment. And let me start with a couple of comments and then some examples for how to think about the difference between risk and uncertainty. And this is very important because a lot of organizations, both paid organizations and provider organizations, when they get into value-based care or concepts of value-based care, they have a tendency to go straight to total costs of care. And that's the biggest of all the pies, clearly, because you're dealing with everything. But it's also very problematic because there's a tremendous amount of variability in any given population, within a population, across populations, in what exactly is it that those individuals have, what are the opportunities for reducing controllable variation, who controls it and has the potential to impact it, and then how does that translate into risk and reward for the different actors. And risk is really the concept of risk is different from uncertainty in that risk is something that typically can be controlled, around which you have the ability to create an impact, whereas uncertainty is just a game of chance. And that's really the key, because a game of chance is exactly that. Maybe you win, maybe you lose, but it's an odds. It's a question of odds. Whereas a game of skill has everything to do with what you can do to impact those outcomes. And where it gets really dangerous in the game of chance is when you are dealing with total costs of care because of all the variability that exists. So what this chart depicts is what happens. You think of each one of the dots represented on this chart are providers, and this is over time, so you've got different colors, but if you forget the differences in colors, think of them as each one of these as providers. And what's on the x-axis is the total number of lives in a total cost of care risk contract. And the y-axis represents the difference between the benchmark. So benchmarks are targets that are set by the payer based on historical data. And so it's a difference between the benchmark and the actual. And so what this chart very clearly depicts is that if you're at the lower end of the scale in the total number of lives that are covered by the risk contract in a total cost of care contract, the greater the variability on the outcomes. And it essentially is a game of chance, right? Severity adjustment, risk adjustment, other methodologies to control for variation in statistics simply breaks down when you don't have very large numbers of plan members in a total cost of care contract. And this has been proven by a number of different academic studies. And I still am shocked when I see providers getting into total cost of care contracts with 1,000, 2,000, 3,000, 4,000 plan members, because the likelihood that they'll win or lose is a flip of the coin. You're just as likely to win as you are to lose, and it has very, very little to do with what you do, and very much to do with what happens randomly during the course of that year. So as you want to get into value-based care and you think about financing of value-based care efforts, you have to get out of contracts that have too much uncertainty and make sure that the contracts have certainty. So how do you do that? Well, in any given population, whether it's Medicare, Medicaid, or commercial, the population is always split into these three zones, and it's more acute. The distribution is more acute and when I say that, it's more striking in commercially insured populations, which this depicts, than others. But for all intents and purposes, you've got a substantial number of individuals, that's the height of the column, a substantial number of individuals who consume very little every year because they have no chronic conditions, they just don't have a whole heck of a lot going on with them. And then you have a small number of individuals, and we all know this, who have extremely high costs because random stuff happens. And when I say random stuff, it's the genes that kick in. You have, a rare form of cancer. You've got a bunch of things that are going on that are incredibly difficult to predict, and whose costs vary massively from individual to individual. So two individuals can have the same condition. The cost of care for each one of those individuals are going to be vastly different. And that's what makes that variation a killer when you have small numbers, because there is no risk adjustment model that can account for what goes on in the tail of the distribution, what's labeled as the insurance zone. However, what happens in the meat of the distribution, where the vast majority of dollars are spent, is perfectly manageable and much, much more predictable, which means that when you get out of total cost of care contracts and into contracts that are either service line specific, disease specific, procedure specific, you're in the manageable zone and the numbers can shrink. So at that point, if you've got 100 patients, 200 patients, the predictability around what happens, the ability to severity adjust, the ability to manage risk becomes much higher when you're in that zone. And this is just another way of depicting this, because in that manageable zone, what happens is what I showed you with the first pie chart on cardiac care, where a lot of the dollars end up by being in acute events, which are controllable, in minor and major procedures, which are controllable, both in terms of the appropriateness as well as the site of care. So as long as you focus on this tranche, which again is where the majority of the people, the majority of the dollars are situated, you will be successful in your value-based payment arrangements. And it's not difficult because you can exclude both tails of the distribution. You can exclude them in any given contract. And the joining point to this is that, remember when I mentioned primary care, even in its most advanced state, only controls 10% of the dollars, while specialty care controls the rest. The goal of a value-based payment arrangement should really be to link the incentives and the payment model for advanced primary care, which can be done on a PMPM basis, with that of specialty care providers, and with everyone having a small slice of their compensation tied to total cost of care. Right? So this is not specifically not designed, and the way in which you can manage that risk and uncertainty is not have, first of all, you can't have everyone responsible for total cost of care, right? That doesn't make sense, because a OB who's just managing maternity is definitely not going to be managing orthopedic care, cardiology care, and as a result, shouldn't be held accountable for total cost of care. A primary care physician, in many instances, is held accountable for total cost of care. But again, unless they have subcontracts of value-based payment arrangements with specialty care providers, they will not be able to really significantly impact the $90 cents on every dollar that goes to specialty care. So the way in which value-based payment models best affect total cost of care, increase value across the delivery system, is by thinking about them in this longitudinal patient care way, where I'm going to start with the right side and move back to the left. So on the right side, if you think about payment centered around a specific event, so it could be the delivery of a baby, it can be a cardiac stent for a patient with cardiology. It could be a back surgery for a patient who has significant spinal problems. All of those can be designed and paid in a bundle payment manner, which today is done relatively frequently. And in those cases, you're really creating a very, very clear boundary around what you're at risk for, which is all manageable. But there can be an element of that which then it gets included into what you hold the specialty care providers accountable for. Why? Because, as I showed earlier, depending on the number of surgeries that are done on an individual, the total costs for that individual are going to change dramatically. So by creating a condition level payment to a specialty care provider, an orthopedist, a cardiologist, a neurologist, whomever, you're embedding the procedures within there and you're controlling for appropriateness. And ultimately, yes, all of this does roll up in total cost of care, but with each one, just like this shows, with each individual provider or provider group responsible for their portion and linked together by some incentive around total cost of care. And it sounds complicated, but it really isn't that complicated. And unfortunately, payers, and this includes Medicare, have defaulted to the easy button. I'm just going to go to the primary care physician and I'm going to hold them accountable for total cost of care. And what I'm hopefully have shown you with this chart is that if you do that and you don't create very, very tight boundaries around your risk, you will win or lose based on just random chance. And there is no way to decrease the randomness of that chance through any severity or adjustment model that exists today. And that basically means that you can win or lose irrespective of what you do in managing the patients in the manageable zone. So this chain of responsibility, accountability, and payment really needs to be designed in a way that each provider group is responsible for their piece, but collectively responsible for the whole. And what that means, practically speaking, for any individual that's included in any one of these arrangements, is that you're shrinking the pie as a whole, because again, you're doing the right thing for the patient at the right time, and at the right place for the right price. And when that happens, the total can shrink. The allocation of the dollars within the total changes, and the portion going to the clinician dramatically increases. So the slice increases in net dollars. This also means that the clinician is going to get more, because a quarter of $500 is more than 13% of $600. So not only does the proportion increase, but the net increases for the clinician, and the value is delivered to everyone, right? The value is delivered to the employee because, or the beneficiary, because they're getting better care, and the value is delivered to the plan sponsor, the employer, the Medicare Advantage plan, the Medicaid managed care plan, because the totals are going down. And while this is for one specific service line, the picture is the same across all service lines if the payment models are delivered the right way. And in fact, this is exactly the reason why financing in healthcare and the availability of capital for practices has dramatically increased over the past 5 years. And in large part because in Medicare fee-for-service, the feds have focused on this type of model for certain specialties. They focused on it for oncology. They focused on it for orthopedics. They focused on it for nephrology. And while it hasn't expanded greatly within the scope of Medicare fee-for-service, that same model is effectively being used in Medicaid managed care around maternity care and mental health and substance use disorder, and in under 65 commercially insured, more and more for many other primary and specialty care providers. And as a result of which, there are literally tens of billions of dollars in capital that are available. All of these organizations listed here, all of them. And I didn't, if I had put all of the organizations that are aggregating practices, helping practices take on value-based care, they would have been logos just absolutely all over this slide. This is the business that they're in. Privia has hundreds of practices across the U.S., primary and specialty or multi-specialty, that they all have assembled under a single tax ID number. They take risk on behalf of those practices, so they help manage the risk. And they're very good at it. VillageMD, you've all heard of, now belongs to Walgreens, and they continue to expand their scope. Optum is probably the better known of all of these organizations, at least within the healthcare industry, because they now have accumulated practices, both single specialty or multi-specialty across the US, and have 70,000 clinicians that are participating in Optum Care, not counting all of the standalone ambulatory surgery centers. One Medical is owned by Amazon. Walmart Health, of course, are the clinics within Walmart. Everside is owned by a private equity firm as its crossover in Marathon. Aledade is its own company with primary care physicians all over the place, and Agilon ditto. So the point being, when you organize your payment, your care along the lines that I've mentioned, the availability of capital has virtually no limits, and even in a I'd say a financing environment like the one we're in now, which isn't great, it knows no bounds when it comes to getting capital to practices that truly want to get into value-based care and value-based payments. Now, I know this doesn't apply to FQHCs for obvious reasons. And so what matters to FQHCs, what should matter to FQHCs, is much more what I referenced to in how do you set up your contracts in such a way as you minimize the potential for random variation. Because you can self-fund this, right? I mean, I think I've shown you multiple ways in which you can increase your slice substantially while decreasing the total pie. And that creates a self-sustaining ability to manage these contracts, grow the practices over time. But it all hinges on the way in which you effectively create the contract. And if you do it exclusively on total cost of care, and you don't have the right quantity of individuals, then you're going to wake up one day, you're going to make money, you're going to wake up the next day, you're going to lose money. And it's virtually impossible to predict year over year whether or not you're going to win in the risk game. And even if you're not a downside risk by the organization, you're still not going to generate, the odds again of generating a surplus based on what you do are random. And so you have to restructure your payment contracts in such a way that you're either completely reducing or eliminating the randomness and creating much more of a predictable way of generating that surplus because of the way both you're compensated as a primary care practice and the specialty care providers are also compensated in such a way that collectively you're going to have the single biggest impact on the total pie and the redistribution of the money within each one of these pies. So with that, let's turn it to questions.
Francois, I've got a question. You spoke about advanced primary care and the role it plays in managing care. And experts agree, as you've pointed out, that reimbursement for primary care practices needs to increase. And the value of doing that will attract additional people coming out of medical school into primary care residencies, and we greatly need to do that. There's a misconception amongst subspecialists, though, that we've encountered here in Texas over the summer, where if you're increasing reimbursement for primary care, you're decreasing reimbursement for the subspecialists. And I'd like to get your thoughts about that. And from what I'm seeing here, it seems to me that that's false, but I'm wondering what your thoughts are.
It is false because this isn't about how much goes to each clinician, but how much is distributed across the pie. And so when you have, like in this instance, a third going to pharmacy, and we all know that that isn't optimized at all, right? More than a third going into inpatient facility, 1/5 going to outpatient facility. This isn't about E&M codes, the number of E&M codes, and the price per E&M code. It really isn't. And I'll give you some very specific examples. And it goes back to when you take a specialty care provider in any given specialty, and you look at, the number of E&M codes, and the price per E&M code, relative to the total, it's a ridiculously small fraction. And that's the point I make to the specialty care providers, and the point also for the primary care physicians, which is you're tackling the wrong slice, right? So everyone sees the world with their own lens, and I've spoken to tons of specialty care providers over the years, and they all think that what they get paid is in fact what is being paid for, fill in the blank, the management of a substance use disorder, the management of a patient's metabolic syndrome, or nephrology care, and it's not. It's maybe 15%, maybe. Everything else is going somewhere else. And they just don't know. So they think of it as a zero-sum game. They look at it from their lens, saying, well, if there's 20% going to clinicians, and we're getting half of that, and the primary care specialty care providers, or the primary care physicians, are getting the other half of that. If we get less than because the primary care physicians get more, then we get less, because they think that these slices are static, that they can't change. And the point is, they're not static at all, because of all of the variation, the controllable variation that creates the other slices. So that's the point, which is there's no reason why the inpatient facility portion should be this high. And it is because you got a significant percentage of acute events that can be prevented with better care coordination. You've got a significant number of procedures that may not be necessary if there's better medical management. The price paid could be different depending on where you go. So overall, and here in the professional slice, I'm not distinguishing in this instance between primary and specialty care providers, but I can tell you that both of them can increase at the same time. It is not a zero-sum game for the physicians. It actually ought to be thought of as in totality as a negative-sum game, meaning we need to decrease the total size of the pie. We have to find a way to decrease. And the point is, it's not that hard because of all the controllable variation. How many of what are you doing? Where are you doing it? And what aren't you doing? And the point is, you're not doing enough E&M, right? So the answer is, you should be doing a lot more management of the patient, and you should be increasing your billings, as long as you're looking at the other slice of the pie and you're delivering commensurate value to the payer, because that's where it's coming out of. It's coming out of facilities, and it's coming out of pharmacy.
So the other argument we hear is that in a really well-managed network where the primary care provider has connections with the specialists, knows where to refer for low costs care, and they're really doing a great job of managing their complex patients, the inpatient stays and the ED visits are going to go down. And the subspecialists that are dependent upon acute events are going to see fewer events to get involved with. So the arguments for hospitals, especially, is that they would rather stay in the fee-for-service model, where they can continue to see high ED visits and inpatient stays. So I'm wondering about that too.
Yes, you are correct. And so look, this is you'll notice that all of these organizations, all of them bar none, and everyone who's providing capital is focused on independent practices. Optum doesn't buy practices that are affiliated with a health system. They only go after independent practices. And there's a reason for that, is because they're independent. And if you're not independent, then your existing compensation, if you're employed by a health system, is tied to the volume of referrals that you are making within the hospital or the health system, right? And so for those, there is no, I don't think there is a clear pathway to really delivering value to payers. But anyone who has an independent practice, there absolutely is a pathway. And I want to address the what you mentioned relative to the subspecialists and those potentially doing a little bit more. And let's just pause a second again to look at the surgical piece, because there is I mean, when you get into subspecialty, there are tons of surgical or procedural subspecialists who focus on very finite scope of practice, and the way this pie is distributed is identical for pretty much any subspecialty that performs a procedure. Because again, those who manage conditions, they can easily expand, they should be expanding their slice, because they're not doing enough of it, because there's too much going into acute events that can be compressed, or pharmacy that's not optimized, et cetera. When you're dealing with a procedure, yes, if your slice is 8.5%, and it's actually going down because the reimbursement to the surgeons is going down because CMS is compressing on it, in large part because that percentage of 75% for the target facility is actually growing and squeezing out some of the other pieces. The way to do that, again, if you're employed by a facility, you've got there is no easy solution. If you're not employed by a facility, then choose the facility. And by doing just a little bit of change in where the patient is being operated in, you can increase your margin per patient by 30% or more. So even if you end up by having fewer procedures, but your margin per procedure is going up dramatically, you're probably doing just as well at the end of the year as you were when you were doing more for less. Now you're just doing a few, maybe fewer, more appropriately, but you're getting a substantially greater margin per patient. So that's really the basis of the economics that exist today. And the issue for most of the surgeons or the subspecialists or the primary care physicians is that they always look at it from that tiny lens, which is their slice. But it's missing the point, because that's just your E&M fee for service or your surgery fees or whatever. And that's not where the money is being spent. The money is being spent everywhere else, right?
Great, thank you.
You're just a small portion of the total.
Any other questions? Please feel free to unmute yourself.
Hi, I have a question. My name is Nina, and let's say you get to a point where from the financial modeling, the primary care physician is ready to start doing this. How do you see it, the implementation happening, and like the collaboration and operations, the culture shift that has to happen?
Well, there are two culture shifts. So there's a culture shift within, well, there are multiple culture shifts. There's a culture shift in how you structure the arrangements with the payer. There's another culture shift, which is internally, then how do you organize yourself so that you understand where the pieces, where there is controllable variation and the impact you can have on that controllable variation. And then there's the third piece, which is your interaction with specialty care providers. And you have to start with the first.
Okay.
If you don't get the payment model structured the right way with the payer, you're in this soup. And I don't know many practices, primary care practices, that have anywhere close to 20,000 attributed plan members, let alone 50 or 60. And this is Medicare, so the variation is bigger than it is in under 65 commercially insured, but the variation in Medicaid is just as bad as it is in Medicare. So you really need big numbers if you're going to reduce that variability in benchmark versus actual on total cost of care. So the first lesson is, unless you're a ginormous system, don't do total cost of care. Solely total cost of care. There could be an element of total cost of care, but if the contract is just, I'm going to hold you accountable for total cost of care. Last year it was $10,000 per Benny, and we're not going to give you any shared savings unless you get it out to $9,500. You might as well ignore the contract, because you have winning or losing is just a question of random chance, irrespective of what the payer tell you. Oh, we got this wonderful severity adjustment. Doesn't matter. It's not going to work. All right. So that's lesson number one. You have to change that dialogue so that what you're structuring the PMPM around is the scope of practice. It's not just the E&M, but it's the entire slice of within the scope of practice, labs, what happened in emergency departments and video. So you try to expand as much as you can that slice, but still within a controllable zone. The margin on those patients should be relatively easy to figure out. How do you create better value by better management, better investment in management, measurable reduction in ED visits and inpatient stays? But that, again, even for advanced primary care practices, if you're lucky, you can get that expanded to about 12% of total costs of care. You're going to be very limited, so your margin is going to be limited. So the balance is really what can be realized collectively with the specialty care providers in impacting their piece, and as a result, total cost of care. And what some groups have done is they've either leveraged existing databases, done analytics to try to find the best specialty care providers in their community, and they try to optimize referrals. The issue is those specialty care providers are still in fee-for-service.
Right.
So, maybe they are legitimately better, they care for their patients better, they have better outcomes, but they're still in fee-for-service. And so the pieces that they could potentially control, they're not controlling. It's just, it ends up by being left in the current state. So I think going and working with a select number of specialty care providers with whom that primary care practice can establish a real professional relationship and saying, let's go together. Here's the deal that we want to negotiate with the payer. Let's go together and you do something similar, but for you, your scope of practice. If you're an OB-GYN, focus on maternity and hysterectomies and a few other things that represent the majority. And let's create something for you that makes sense for you. And between the both of us, and plus a couple of others, if we go together, we're still independent, but we now have an opportunity to win for what we do and collectively win on total cost of care. Because you now have everyone essentially working towards a common goal, which is the optimization of care of the patient. And ultimately, that means total cost of care. And for all intents and purposes, what I'm describing is what quote unquote ACOs were supposed to be. But the challenge with the ACO is that in a center, instead of being an advanced primary care practice, is a health system.
Mm-hmm.
And you're asking the health systems for the impossible, which is to cannibalize their revenue. So it doesn't work. But nothing precludes the practices from working together and figuring out a way to create a better model for each of them and deliver better value for the payer. And, I'm not saying it's easy, because most payers, they find this too complicated. But there's an increasing number who realize that whether it's Medicare Advantage or Medicaid, just going to the primary care physicians and saying, you're on the hook, is not effective. It's just not effective. So you need to figure out another way.
Yeah, thank you for that. And I imagine that if that's possible to get everybody aligned, the specialty and the primary care, I think about too, just the isolation that a lot of providers talk about. And so building up that support and it contributing to burnout. Has there been any discussion or outcomes from that perspective?
That's right. And also remember that the primary care physician, unless it's an HQHC, has other patients from other payers. And it's the same thing with the orthos. It's the same thing with maternity. You know, maternity, typically an OB group has somewhere between 40 and 50% of the maternity cases are Medicaid, and the balance is commercially insured individuals. So the idea is, don't do it for one payer, do it for multiple payers. Because you really need a critical mass of the covered lives, the patients that you care for in these models to create the sustainable margin that you need in order to have all of the processes to optimize care. If you just do it on a small slice of your patients, it's really tough. And the specialty care providers won't do it for just a small slice of their patients. So it's important to have this dialogue first, to find the folks with whom you can work. Almost every practice, has roughly, and the specialty care practices are the same. They have the same kind of distribution of patients. There's a chunk in MA. There's a chunk with the local Blue plan because that's a larger commercial payer. There's a chunk in, with United. I mean, it's not as if there's thousands and thousands of different payers that you have to worry about. I mean, you have maybe 5 payers in any practice. That represents the vast majority of the patients that they care for and for which they're getting paid. So if you can get 2 or 3 of those payers to agree to the payment model, then you have yourself a real game.
Great, thank you.
I don't see any questions in the chat. So does anyone else have any questions? Dr. Pearl, you were going to say something?
No,
Okay, looks like we are all set for the day then. If you do think of any questions, feel free to reach out to us and I'll be happy to forward your questions to Francois and get you connected that way as well. But if you guys don't have any questions, thank you all for joining us today. Francois, thank you so much for your time today and for doing this incredible session. It was really informative and I'm sure we all learned a lot. Victoria, are you still on the call? Okay.
Yes.
Close this out.
So as always, I will be sending out a follow-up email, and that'll include Francois' presentation. It'll include the recording of the session as well as the link to the evaluation survey. So just please be sure to fill out the survey to receive your CEU credit, your certificate attendance for that. That's it. Thank you all so much. Have a great day.
Thank you.
thanks, Francois.